It's been a pleasure meeting you. Today we have, as Dr. Rakesh mentioned, a very important topic regarding the pre-operative evaluation of cancer patients. As we all know, the pre-operative evaluation of cancer patients and their conditions poses a different set of challenges specific to the disease. Basically, the evaluation must include an assessment of their functional status, nutritional status, and their symptom control, especially with relation to pain. But we all know that that is not enough. There are lots more things to be seen, lot more history to be taken, many more records to be seen, and certain specific preoperative tests and preparations to be done before we actually give the fitness for surgery. All these things will be elaborated by Dr. Aditi Tilak. Dr. Aditi Tilak is a consultant in onco anaesthesia at Nanavati Max Super Specialty Hospital at Mumbai. I welcome you, Dr. Aditi, and hand over the mic to you. Please proceed.
Thank you, sir. Should I share my screen?
Yes, please.
Is my screen visible?
Yes, it is visible. It is visible.
Okay, thank you, sir. Good evening, everybody. Greetings from Mumbai. I'm Dr. Aditi Tilak. I'm a consultant onco-anesthetist at the Nanavati Max Institute of Cancer Care in Mumbai. And the topic for discussion today is the preoperative evaluation of the cancer patient. This is the brief scope of what we'll be discussing today. First, the importance of preoperative assessment. Why do we do it at all? And especially its significance in the cancer patient. Then some common points of assessment that are true for all surgical patients. And then we come to the concerns specific to cancer patients and the recommendations for these health conditions, these deficiencies, and how to treat them if possible. And then we'll summarize it all together into our usual format of pre-op assessment and have a take-home message at the end, hopefully. So why do we do a preoperative assessment of any patient? First, we want to know our patient in and out well enough so that we can plan their anesthetic management in the most optimum manner. We want to know about their disease, their symptoms, its progression, and we want to know about the treatment taken. Secondly, if there is anything modifiable in the patient's condition, if there is anything we can improve, then we want to achieve that in the pre-op period. The fitter the patient who comes to the operating table, the better their recovery is going to be and the better they're going to rehabilitate. While this is true for all patients, it is extremely important for the cancer patient because surgery is only part of the treatment of our patients. Following that, they are expected to undergo a rigorous regimen of chemotherapy, radiation, and deal with a lot of complicated treatments. So if at the end of our surgical period, the patient is fit enough to undergo this treatment, that defines the success of surgery. This is why early return to intended oncotherapy is one of the metrics which is under study currently. And it has been seen in early studies that the earlier the return to intended oncotherapy, the better the long-term survival of the patient. So the goal of our surgery and anesthesia plan should be an early riot. And this can be achieved if we know our patient, optimize them well enough, and then bring them to the operating table. What do we evaluate all our patients for? We want to know about their existing comorbidities. We keep in mind what surgery they're having so that we can plan our anesthetic according to both these factors. And in the cancer patient, there are certain other issues which must be borne in mind, which may not be seen in the general surgical population necessarily, but it is related to the disease and to its treatment. And so it becomes extremely important to bear these factors in mind while doing the pre-op assessment of these patients. So the existing comorbidities, all our patients are evaluated for their pre-morbid conditions like hypertension, diabetes, COPD, thyroid dysfunction. We all know that any patient who has an existing comorbidity carries a higher risk of perioperative morbidity. This is even more so if these conditions are not well controlled. And that is why we have several scoring systems like the NSQIP, the revised cardiac risk index, the PPOSM score, the very basic ASA physical status score. All of these are meant to risk stratify the patient so that we know how complicated the patient is who we are dealing with. And also, we can explain to the patient and the family about the perioperative risk of morbidity and mortality. It helps us immensely in counseling and taking the appropriate consents from the patient. In a cancer patient, these factors are very, very important because sometimes these may be the only things that you can improve about your patient. You may not be able to do much about, say, the side effects of cancer chemotherapy and radiation, or you may not be able to immediately make a frail cancer patient into a robust specimen coming onto the table. But in the couple of days that are available before surgery, you can definitely put them on the right treatment for hypertension, diabetes, start them on thyroid medication, and thus start them on the pathway of optimizing them from the point of view of these comorbidities. It is also very important to note that what are the routine medications that the patient is taking at this time, so that you can give them clear instructions about which medications to continue taking right up to the day of surgery and which medications need to be stopped. This is particularly significant with respect to drugs like beta blockers or your oral hypoglycemic agents and your blood thinners, because you can plan your anesthetic accordingly. Whether or not you do a regional technique depends upon the time of stopping of your blood thinners. Surgery specific concerns, we always bear in mind what surgery is this patient having. It decides our anesthetic plan majorly. In cancer surgeries, particularly, there are certain procedures which put the patient through a lot. They are very challenging for the patient and for us in terms of extremes of positioning, which can be seen in robotic surgeries. In case the tumor involves vascular structures or is very close to vascular structures, you can anticipate that there will be major blood loss, fluid shifts in major abdominal surgeries. Another area of concern from the surgical point of view is head and neck surgeries and thoracic surgeries, where there's likely to be a shared airway between the anesthetist and the surgeon. Anatomical sites of the tumor can make your intubation and ventilation very difficult. So a thorough airway assessment and having a clear plan of airway management is essential. Similarly, for thoracic surgeries, a clear plan of what the ventilation is going to be like intraoperatively is extremely important. So a patient needs to be evaluated from these points of view, that are they going to be able to withstand these challenges of the surgery, and how are we going to plan our anesthetic so that they withstand these challenges to the best. These are some of the concerns which are very specific to the cancer patient, which may not be seen in every surgical patient that we encounter otherwise. And we're going to go through them one by one. Nutrition is of major concern in the cancer patient. By definition, cancer is a hypermetabolic or even a catabolic state. It is an unregulated cell growth. So it's quite obvious that if your energy supply is not meeting your demand for energy, the patient is going to be losing weight. So the disease itself predisposes the patient to weight loss. On top of that, you have the cancer treatment, which can induce anorexia and nausea. They are the commonest side effects of most cancer treatments. That further reduces their oral intake. Other side effects like stomatitis, mucositis make the patient actually fear putting anything into their mouth. Pain at any site can reduce the appetite of the patient just because their mind is so consumed by that pain that they may not be able to take food appropriately. In certain oral, pharyngeal, or even upper GI cancers, there can be a mechanical obstruction along the pathway of food, limiting their oral intake. So the causes of compromised nutrition are multifold in the cancer patient. But does it mean that we go straight away to parenteral nutrition or to enteral nutrition? Ideally, these should be reserved only if there is enough time available to achieve their benefit, and only in the severely malnourished patients before surgery. It should not be a matter of routine to treat all malnourished cancer patients with parenteral or even enteral feeding. According to the recommendations of the European Society of Parenteral and Enteral Nutrition, certain steps can be taken throughout the treatment of the cancer patient to optimize their nutrition. Early and continuous involvement of a nutritionist at any point whenever the patient needs to visit a hospital, or if there is a fresh concern, a nutritionist should be involved in the treatment plan of the patient. They can do an early assessment of the body composition, the energy expenditure, depending upon the level of physical function and activity, levels of inflammatory biomarkers. All these can help to determine what is the patient's energy requirement, and accordingly, a diet plan can be made. They recommend a high protein intake of at least 1 to 1.5 gram per kg per day, and more energy from fats rather than from carbohydrates, so that the caloric requirement of the patient is met, but the glycemic index should be maintained low. And most importantly, all the steps that can be taken to treat the conditions limiting the oral intake. All these steps need to be taken, giving the patient antiemetics, analgesics, antidepressants, prokinetics. All this can help them to actually consume food the normal way, which is not just the most physiological way, but probably the most satisfying thing for a patient. If there's any mechanical obstruction, then this can be bypassed using an enteral method of feeding. But that is after all these other simple measures have been tried to treat the other causes of anorexia. And parenteral nutrition, like I earlier mentioned, should be the last resort. Hypoalbuminemia is often because of poor oral intake. So if you take care of the malnutrition, then the hypoalbuminemia usually corrects itself. If not, then other causes of low albumin levels like sepsis or coexisting organ dysfunction with liver failure, kidney failure, or heart failure should be looked into. Low albumin level is an independent risk factor for poor perioperative outcomes, especially in GI surgeries. And so we are seeing increasing use of IV albumin in the perioperative period. This is one factor to be noted in the immediate pre-op and post-op period. Anemia is another nutritional deficiency because of poor intake, or it could be because of chronic blood loss caused by the disease itself, marrow infiltration caused by hematological tumors, or myelosuppression caused by the cancer treatment. There is no one fixed value of hemoglobin that is recommended universally that has to be achieved preoperatively. But studies have shown that when the hemoglobin post-op is less than 8 gram per deciliter, for every gram per deciliter decrease in hemoglobin below 8, there is a 2.5 times increase in the perioperative morbidity. So every attempt should be made to optimize the patient's hemoglobin. How is this done? Preoperatively, oral iron. It's useful if you have enough time on hand. It needs at least 6 to 8 weeks to act. IV iron, on the other hand, works even if there is lesser time in hand. So there's no clear recommendation about which iron therapy, oral versus IV, to prefer in which patient group. But instinctively, it feels as if your patient's oral intake is compromised and you don't know the exact cause of iron deficiency, whether it's malabsorption or poor intake, and time in hand is limited, then IV iron supplementation seems to make more sense in our patients. If there is no iron deficiency, then erythropoietin stimulating agent is the next step in the treatment of anemia. But it increases the risk of tumor recurrence, secondary cancers, especially urothelial tumors. Plus, it puts the patient at increased risk of thrombosis, and so it must be used with caution. And the last resort, blood transfusion. Just like anemia is associated with poor outcomes, blood transfusion has its own set of complications and risks. In onco studies, it has been seen that it is associated with a higher incidence of cancer recurrence, metastasis, and therefore death. If at all, transfusion needs to be given in the fewest possible units to achieve a target hemoglobin should be RA. And using leukodepleted packed cells helps to reduce the incidence of transfusion-related immunomodulation. Like anemia, another hematological abnormality in our patients is the high risk of thrombosis. Chemotherapy increases the risk of thrombosis, and so does the disease itself. There are high circulating levels of clotting factors, cytokines, factors like cancer procoagulant, tissue plasminogen activator. The tumor itself can form a thrombus within the vessel. And high incidence of forming a thrombus means that there's always a risk of an embolus forming and leading to further complications. So these patients are always at very high risk of venous thromboembolism. In the peri-op period, this risk is further multiplied. There is a period of immobilization that is associated with surgery. First, the long duration of surgery during which the patient lies on the operating table. Following that, the immediate mobilization is not going to be as good as before. It will take a few days, if not a few weeks, for the patient to achieve the same level of mobility that he had pre-op. So in the peri-op period, thromboprophylaxis is a must. Mechanical thromboprophylaxis is in the form of your pneumatic compression boots, stockings, and pharmacoprophylaxis using either low molecular weight heparin or the newer oral anticoagulants like fondaparinux, apixaban, dabigatran. These are also recommended. According to the 2019 American Society of Clinical Oncology guidelines, chemical thromboprophylaxis is recommended for all major cancer surgery patients. Also, onco patients who have acute medical conditions needing hospitalization or for very high-risk outpatients who had previous episodes of thrombosis. So we should expect that most of our patients coming for surgery could be on some kind of thromboprophylaxis, and an adequate time interval between the last dose of your thromboprophylaxis and surgery, and if you're planning regional anesthetic, that must be borne in mind. Leukopenia and thrombocytopenia are often seen in hematological malignancies. Any chemotherapy can cause these as well. All the neutropenic and leukopenic patients are at very high risk of infection. So strict asepsis during the peri-op period and a very quick response to fever with broad spectrum antibiotics is a must. Use of colony stimulating factors as primary prophylaxis to prevent febrile neutropenia or neutropenic fever can also be considered. As for platelets, a count of more than 50,000 is considered adequate for most surgeries. But if you're expecting that there will be the surgeries at a very crucial site, then you could consider a platelet transfusion preoperatively. This is surgery, surgeon to surgeon. We'll come to the electrolyte and endocrine abnormalities which are seen in the onco patients. Since steroids form a part of most cancer treatments, they are either used in the primary chemotherapy regimen or they are used to prevent nausea vomiting that is associated with chemotherapy. So we expect that anyone who has had more than 5 mg per day of prednisone for more than 3 weeks or an equivalent dose for more than 3 weeks is at risk of hypothalamic-pituitary axis suppression. These patients will need a stress dose of steroid preoperatively. Similarly, if there is refractory hypertension in the peri-op period, in the intra-op or the immediate post-op period, then the possibility of hypothalamic-pituitary axis suppression should be kept in mind, and a stress dose of steroid can actually help to treat this hypertension as well. Thyroid dysfunction is often seen in patients who had irradiation given to the neck, and therefore the thyroid function tests need to be checked and they need to be on the appropriate medication. Hyponatremia can be seen in the frail cancer patient. Sodium levels of less than 135 millimoles per liter carries a higher 30-day mortality. Hyponatremia is usually a marker of some underlying organ dysfunction, and so it should alert us to look for that organ dysfunction, and treating this primary cause is the best way to deal with this hyponatremia. Frailty is an integral part of most cancers. Just to understand what it means, frailty is progressive age-related decline across physiological systems, which leads to decreased reserves of capacity and increased vulnerability to stressors, which again puts the patient at increased risk of adverse health outcomes. It is essential for treatment planning and for predicting outcomes that we assess how frail is our patient. It is often seen that frailty is overlapping with the geriatric population in the general population. However, cancer is one condition where even a young patient who has been through the ravages of the disease and the treatment really seem to be extremely frail. There are many scoring systems like the Frail Index, Clinical Frailty Score, Gait Speed, all of which take into account what is the level of physical activity that this patient is doing, what is their muscle mass like, and they calculate objectively the frailty of the patient. Like I said before, we may not be able to reverse the frailty immediately, and especially in the limited time that we have. But we can definitely take simple measures like stopping smoking, stop alcohol consumption. If there is time available for some reason, then an exercise program in which slowly the patient can be rehabilitated to increase their activity can be extremely useful. But unfortunately, it's not realistically possible. A higher protein consumption of about 1 to 1.2 gram per kg per day can be extremely useful, and supplementation of vitamins and micronutrients can be useful as well. Optimizing the medical management of comorbidities and avoiding polypharmacy can go a long way in managing such patients. Chronic pain, again, is a component of most advanced cancers. And if the patient has been using over-the-counter analgesics, then long-term use of NSAIDs and its associated complications are seen in this population. Checking the renal function tests, checking the platelet count to make sure that there is no nephrotoxicity or low platelet count is a basic screen. If the patient is already taking opioids, then you can expect that this patient is going to be having opioid tolerance, hyperalgesia, and is at risk of withdrawal in the perioperative period. What we can do is document the total daily dose that the patient is taking and then plan accordingly for the perioperative period by supplementing this basal dose with an additional dose to meet the requirements of the immediate post-surgical period. The use of partial agonists and antagonists is strictly forbidden because it can precipitate withdrawal in these patients. Multimodal analgesia regimens which incorporate NSAIDs, gabapentinoids, along with a baseline acetaminophen can help to limit the dose of opioids. And using regional techniques is the best thing one can do for these patients to keep their other analgesic requirements under control. Very, very important is to counsel the patient preoperatively and discuss the analgesia plan with them so that we can have them on board with the plan. Getting the patient's cooperation, getting their confidence can definitely increase their satisfaction. We'll just go through some organ system dysfunctions, which can either be tumor induced or it can be treatment induced. Since we discussed the effects of cancer chemotherapy and radiation in depth a couple of weeks back, I will try not to repeat too much, but to complete our topic, I will just go through the organ systems briefly. In the cardiovascular system, cardiotoxicity caused by anthracyclines, trastuzumab is well known. It is dose dependent and it can even lead to heart failure. But before heart failure sets in, subtle ECG abnormalities and subtle signs of impending heart failure can be picked up in these patients. Radiation can induce premature coronary artery disease, carotid stenosis, and even valvular heart disease. Myocarditis can develop not just as a result of chemotherapy but also immunotherapy. And certain tumors can involve major blood vessels by themselves. They can either compress the lumens or can have intraluminal growths, which should be noted during a preoperative assessment. The mass effect of mediastinal tumors should be noted, and we should expect that it will be a stormy course in trauma. In the respiratory system, bleomycin-induced pulmonary toxicity can manifest years after treatment. Similarly, immunotherapy and radiation also induce pneumonitis. If there is gross peritoneal disease, there will be ascites in the advanced stages of the disease, which can lead to pleural effusion, and it definitely leads to lung atelectasis and respiratory compromise. Hepatotoxicity is usually induced by chemotherapy agents like oxaliplatin, tamoxifen. Similarly, reactivation of hepatitis infection, especially hepatitis B, must be borne in mind in patients receiving chemotherapy. Nephrotoxicity, cisplatin is the most commonly implicated agent, and wound healing is often impaired by the anti-angiogenic agents and small molecule tyrosine kinase inhibitors. These agents target the vascular endothelial growth factor, and so they can impair wound healing and can have implications in the post-operative period. An adequate time interval between the last dose of these drugs and the planned surgery is essential. So now that we've seen the various effects of cancer and cancer treatment on the patient physiology, let's put it all together into our usual format of history taking, examination, investigations, and make a plan for our anesthetic. When we take the history of cancer patients, we want to know the symptoms of their disease, how they've progressed, what is the treatment that the patient has received, and how they've responded to that, whether there have been any complications of the same. How much is the patient able to do in their day-to-day life? This gives us information about their effort tolerance and cardiorespiratory reserve. Questions about occupation, family history, and addictions will help us understand the why of cancer because they play a big role in the pathogenesis of certain tumors. Similarly, in the history, a list of routine medications so that we can give the appropriate advice regarding discontinuation of medicines must be done. In examination, the general examination itself gives us a lot of clues about the stage of cancer, the progress of cancer in our patient. Pallor, icterus, clubbing, edema, sarcopenia. These are often seen in advanced cancers. A thorough airway examination is essential, especially for head and neck cancers. This is a good point where we can check the IV access and the potential sites of IV cannulation in our patient. The presence and absence of chemoport needs to be noted. In the cardiovascular system, signs of failure, presence of any murmurs, presence of pleural effusions, chest infections, or massive ascites are necessary for examination of the respiratory system. And in the neurological system, any neuropathies or any signs of focal neurological deficit must alert one to the possibility of metastasis. Neuropathies can be a feature of your cancer chemotherapy side effects as well. Investigations include the whole plethora of routine investigations, right from your CBC, your kidney, liver, and thyroid function tests and coagulation profile, imaging like your chest X-ray, and specialized scans like CT scans, PET scans, which will tell us about the size, the site, and the extent of the tumor, presence or absence of vascular involvement. An echocardiogram is usually done in all the post-chemotherapy patients, and more specialized tests depending upon the condition of the patient and the site of the tumor, like your pulmonary function tests, venous Dopplers, a stress test, as indicated. Once we have all this information from the history, examination, and investigations, we want to take appropriate consents from the patient for anesthesia, make a plan for post-op pain management and explain it to them, take consents as needed for blood transfusion, invasive lines, intensive care, post-op ventilation, and any other advanced treatment that might be necessary in the perioperative period. So, if there is a take-home message that I would like to give, it is that we want to know our patient, we want to thoroughly assess our patient, and we want to optimize them as much as possible. But this is bearing in mind that cancer surgeries are urgent surgeries, if not emergent surgeries, and we cannot be delaying the treatment of the patient for the most optimum optimization. At times, and many a times, we will have to accept the patient in the current condition or in the after a very limited optimization and still do the best possible for them. So a tailored anesthetic bearing in mind the current condition of the patient, the surgery plan to achieve that goal of early return to intended oncotherapy should be our goal. These are my references and thank you for your patient listening.
Thank you very much, Dr. Aditi. It was a very lucid talk on the preoperative evaluation of cancer patient. As you mentioned, a detailed history is very important. An idea of the patient's medications which the patient is taking, especially the chemotherapeutic drugs which have been taken, and also the history of radiotherapy is very important. And in addition to all the battery of tests which you have suggested, I would also like to mention a few simple tests which can be done to assess the patient's general condition by the bedside, is like a 6-minute walk test or a breath holding test. That also will give a superficial idea of the patient's functional capacity. So having said this, it is very important for us to evaluate the patient who is going to undergo cancer surgery in detail. And one must not bypass any of these things lest we land up with trouble during the perioperative period. Thank you very much, Dr. Aditi. If there are any questions, I would like to, you could ask Dr. Aditi, please. Any questions from the audience?
At the moment, I don't think we have anything in the chat box.
Okay.
As of now, we haven't received so much questions, but thank you, sir. Thank you for your wonderful deliberations.
Thank you.
Thank you. Thank you, everyone. Thank you for being there. We are more than grateful for having you and this platform, and hoping to meet you again for your next session very soon.
Thank you, ma'am. Thank you.
Thank you so much, everyone. So with all your permission, we are concluding the session over here.
Just 1 minute. Does
Yes.
Dr. Rakesh want to say something?
Yes, ma'am. Yes.
I think well covered. Everything was fine. Yeah, I think we'll discuss separately. So maybe Dr. Anjali can welcome for the next session, and we'll share the details.
Yeah, I think we'll talk in the next session. If anybody has any questions, please post them in the group. If somebody's not posted them in the chat. And is it okay to call it off, Dr. Rakesh?
Yeah. Thank you.
Thank you,
everybody.
Thank you, sir.
Thank you so much. Thank you. Thank you, sir. Thanks.